Hi, good evening, everybody. Welcome to another session of this Wednesday webinar by Beating Hearts. Today, we are actually touching on a very important topic because it's a very new disease and we want to create awareness as this disease affects a lot of kids and mortality is high if it's not detected or diagnosed early. So we have here with us Dr. Ang. Thanks, Ang, for coming in. He's a consultant pediatric cardiologist with Sunway Medical Center. So Ang, maybe you'd like to start?
Okay, thank you. Good evening. Thank you for joining our webinar. Thank you, Dr. Betty. So you are the bigger beating heart, I'm small beating heart.
Oh, yes.
So today we are talking and discussing about, I would say it's discussing about this MISC, Multisystem Inflammatory Syndrome in children. So a syndrome that only known to us for less than 2 years. Yeah, so the how to diagnose it, criteria, treatment is still evolving. So it's quite a pretty new disease. But we say important, like just now we chit-chat, we expect our peak of MIC cases will be next month. Yeah, after the MCO is lifted, we can see there's a lot of COVID cases. And I think either reported or unreported cases of children with COVID-19, I think is a lot and very high. So as for introduction, COVID-19 infection in children usually mild. So you see, until today, besides China, vaccine them until 3 years old. That means anyone above 3 years old, they give the vaccine. In US, Malaysia, we don't give to the children that's more than 5 years old. So it's because like most of the time, COVID-19 infection in children are usually mild, and most of them are okay. So this one is informal data I get from KKM. You see, from 29 December 2019 to 26 February 2022, there is 134 pediatric deaths. It come out to 0.41%. So this mortality rate probably will be lower because I believe there's a lot of unreported cases. So the denominator will be much lower. That's why the mortality rate come out to 0.41%, and 79% or nearly 80%, 4 out of 5 of them have comorbidity. Majority are those with Down syndrome, neurological deficit, lung or heart issue, and so on. So this disease for children is quite mild, but the complication is bad. So why we say this syndrome, MISC, is only known to us for less than 2 years. Only in April 2020, UK reported a few cases quite similar to, their presentation are quite similar to Kawasaki disease or toxic shock syndrome. And initially there's many names. They call it, of course, one is MISC, some they call it pediatric multisystem inflammatory syndrome, pediatric inflammatory multisystem syndrome, temporary associated with SARS, and pediatric hyperinflammatory syndrome, and some actually call it pediatric hyperinflammatory shock because they usually presented with shock. So like in May, and this published in August, in US, you see, AHA came out with an article that they found that this new syndrome that children actually experience acute decompensation following following the COVID infection with a severe inflammatory state. Okay, and their treatment actually is IVIG, and a lot of them recover. And they found that there's a new syndrome with acute heart failure. So initially they are called it hyperinflammatory shock in children. Okay, what is MISC? So it's a severe acute respiratory syndrome, coronavirus 2 related syndrome. It categorized by fever, inflammation, multi-organ dysfunction, and manifest late in the course of COVID-19 infection. And up to today, the incidence of MISC is still uncertain. We're not quite sure. And I think for US, they quoted actually less than 1%. So it's relatively a rare complication. and mostly occur in older children or adolescents and who were previously healthy. So a bit different compared to Kawasaki. Kawasaki, majority of them are less than 5 years old, but for MISC, majority of them are between 5 to 12. So the mean age is about 9 to 10. And it's also different than severe acute COVID-19 illness because most of them, those children with severe COVID-19 illness, they have underlying or comorbidity. So this is how the epidemiology is different. And actually for US, they found that they are more common in the Black and also Hispanic compared to Asian kids. So we should be relatively more protected. So this is the diagram that posted in DG Twitter. I think everybody also saw this, okay? So from this side, you can see they only reported 174 cases from June 2020 to December 2021. And majority, of course, they will say this is because they want them to go for vaccination. So more than 50% are in between 5 to 11. But in the real situation, yes, majority of the cases are this group, and the mean age is about 9 to 10 years old. And Malaysia, we reported 7 deaths from this MISC. And majority of them require pediatric ICU care. But we're not sure whether we are underdiagnosed because when I look through a lot of articles and also publication in US, UK, and so on, the shock or left ventricular dysfunction is only about 50 to 60% mostly. But I can see for this, our MISC study group, the LV dysfunction is up to 100%, and 68% of them actually have shock. So a bit high compared to those reported in other countries. And okay, so of course, like for this disease, one of the important thing is the GI symptoms. And for this one from our MISC study group, 83% they have GI involvement. Diarrhea, nausea, vomiting is quite common. And one of the characteristics is a lot of children actually presented with severe acute abdominal pain. A lot of them was misdiagnosed appendicitis, acute abdomen. So this was very prominent feature. Okay, others is quite similar to Kawasaki. They will have conjunctivitis, red lip, cracked lip, and so on. Okay. Okay, what is the pathophysiology? We're not quite sure. So it's quite similar. A lot of experts think this is also an immune-mediated vasculitic lesion. Okay, for patients with severe IIC, what they found is they have persistent IgG antibody to enhance and to activate the monocyte and causing a persistent cytopenia. So for those severe cases, they have lymphopenia. Their lymphocytes are less than 1,000. Okay, yeah, neutrophils are high. And most of them tested negative for PCR, for COVID PCR. And from the autopsy, we found that a lot of them will have myocarditis, pericarditis, endocarditis. If you ask me how to differentiate from myocarditis, it's a real issue. Okay, but of course for MISC with a name that multisystem, so of course if we have more than one system involvement, we have to call it MISC instead of myocarditis. Of course, that's why when we discuss with friends, they will say, hey, how you actually differentiate it from myocarditis. Okay, the duration. So usually the disease is for 2 to 6 weeks following the onset of COVID infection. Okay, so after you get the day one, you get the COVID infection. Oh, maybe we talk about COVID-19 infection in children. I see most of them we have about fever about 2-3 days. May have vomiting and diarrhea, but majority of them doesn't require admission. So of course, some that will go into pulmonary phase also, they will cough, wheezing on day 5 to day 7. But majority recover well, except for those with comorbid. So I always advise I give a nurses talk also about a few weeks ago. Also advise them to watch out for their kids whenever they have fever 2 to 6 weeks later after getting the COVID infection. And this MIC have wide spectrum of disease severity and usually presented with 3 to 5 days of fever. For Kawasaki, we need 5 days, so-called in the criteria, you have persistent fever for 5 days. But COVID, MIC, we just need about 3 to 5 days. Some even as long as more than 24 hours is enough. And they either have a short or multi-system involvement. Okay, in terms of clinical manifestation, of course, persistent fever more than 38 degrees, more than 1 day, I would say is enough. Majority, nearly 100% of them will have a GI symptom. Remember, vomiting, nausea, diarrhea, but what important in MIC compared to severe COVID, Kawasaki, and so on, is they have a severe abdominal pain. A lot of them actually present with acute abdomen and they have rashes. They either have a petechial rash, maculopapular rash, or polymorphic rash. Same thing, they have a non-purulent conjunctivitis. They have a red lips and also tongue. And majority of them also, the kids will become very lethargy, very unwell, and not active. Okay. Some of them, I would say slightly more than 50% of them will have a respiratory symptom. And a lot of them actually is also related to the poor cardiac function. Lymphadenopathy is not very common. Swollen hand, feet, myalgia, and sore throat is not very common as well. And how they present, you see the initial in 2020, majority of them actually presented with shock. That's why they recognize this MISC. Second, they found there is a large number of patients actually meet the criteria of Kawasaki disease and myocardial dysfunction. And in the MIC also, we routinely actually have to do the ECG frequently, at least every 40 hours to monitor for arrhythmia. They have a risk of cardiac heart block as well. They may have acute respiratory failure, but majority of respiratory distress and acute respiratory failure are related to poor cardiac function. They can have an AKI, acute kidney injury, and quite a number of them, about 10% of them, will have pericardial effusion, pericarditis, pleural effusion, and ascites. And some do present encephalopathy, hepatitis, and so on. So this lab test is important. I think if you look at this, most of them we have this test. So most, I think, whenever we suspect patient have MIC, certainly we do a full blood count, and this lab marker are very important and it correlate well to the severity of disease. Those who have very low lymphocyte, less than 1,000, neutrophil, they define as more than neutrophilia. Actually, in most of the MIC, they are more than nearly about 8,000. They do have mild anemia, similar to Kawasaki, and thrombocytopenia, platelet count less than 150, correlate well with the severity of disease. Of course, they have very high CRP, ESR. Their CRP and ESR even higher than Kawasaki disease. D-dimer more than 2, 5-minogen, ferritin more than 500, hypocalcitonin, and so on. A lot of them do have high TROP-T, TROP-I, BMP, low albumin, quite similar to KD, high liver enzyme similar to KD, LDH, and high triglyceride. Okay. So cardiac involvement is common. Of course, like you see the what we posted in Malaysia MIC study group is 100%, but most of the study I checked is majority is about, the most is about 50 to 60%. So it's either we actually underreported our case or we don't detect. We only actually detect those that we only reporting those like very severe MISC, because MIC have a whole spectrum of disease. And the coronary artery involvement is not as common as Kawasaki disease. It's around 20%. Kawasaki is even untreated is more than 25%. And so coronary artery involvement, I think, is also an important key feature to distinguish it from MIC from acute COVID-19. COVID-19 cases won't have coronary artery aneurysm. And in terms of cardiac involvement, this one is an informal data I get from the pediatric ICU in some of the KKM hospital. More than about 50% of them will require inotropic support and also ventilatory support. So about 50%. Okay. So this is the case definition. So there's a different case definition because this disease is still evolving. So they don't have a Professor Kawasaki to describe the Kawasaki. So this MIC, everyone have their own one. WHO, they define as different. That's why they need a deep fever more than 3 days. But Royal College of Pediatric and Child Health just said need a fever. CDC just need more than 24 hours. But majority of them we have need to have a multi-organ involvement. Okay. But WHO, they want to define it. They have the cardiac involvement, shock, and so on. Yeah, they take it in consideration. Of course, again, MIC is also a diagnosis of exclusion. So we always exclude other disease. Plus, we have to have a link to the COVID-19 infection. Okay, so what we say, okay, it's a clinical spectrum of disease. So of course, in acute COVID-19, majority of 90% of children have a very mild disease. Those with a severe one usually have comorbid. Similar thing, of course, like, so this one is COVID-19 associated MISC. So this one also we have a little bit of debate because some of the expert think all the children must be admitted. So because they believe it's a severe one, but some do think that may actually presented with persistent fever, a bit lethargic, a bit high inflammatory marker. There's more than one organ involvement, but may not involve the heart, and they may not presented with shock. So they actually can treat an outpatient. So they just a febrile inflammatory state. Some actually quite similar to Kawasaki disease. Again, they're not going to shock. But from the data we get, it's like at least 50% of them we have severe MISC. Though the main cardiac involvement is certainly more than 50%. So I would say this disease is still evolving. So we actually don't define it very well and so on. So maybe we have a different definition in near future. Okay. This will be similar thing like talking about MISC, Kawasaki, and toxic shock syndrome. Okay. How are we going to distinguish MISC from Kawasaki? Okay. MISC affected older children and adolescents. KD, majority of them are less than 5 years old, and those with severe Kawasaki disease are usually around 1 year old or less than 1 year old. Second important feature is MISC. Nearly 90% of them will have GI symptoms, and their abdominal pain are very severe and always diagnosed as acute abdomen before actually they actually re-diagnosis with MISC. And so, of course, in Kawasaki disease, they do present with diarrhea, vomiting, but it's not that common compared to MISC. And myocardial dysfunction and shock is more than 50% in MISC compared to KD. KD, even though there's something called Kawasaki disease shock syndrome, but it's not common, especially in Asia. We seldom see KDS as Kawasaki disease shock syndrome. But MISC, more than 50%, they have myocardial dysfunction and also shock. The inflammatory marker tends to be higher in MISC compared to Kawasaki disease or Kawasaki shock syndrome. And lymphocyte tends to be lower. They have a lymphocytopenia, and platelet count tends to be lower in MISC. In KD, after 7 days, they will have thrombocytosis. So that is a feature that is differentiate KD from MISC. So of course, it's not very clear what is the risk of coronary artery involvement in MIC compared to KD. But in general, when Professor Kawasaki described classical KD, there is about 25 to 30% of coronary artery involvement if we don't give the IVIG. But in MISC, it's actually less than 20%. I think most of the study found that about 15 to 20%, some even lower than 15%. So certainly coronary artery involvement will be lower. So talking to our KKM friend, what they found is even in MISC, if the coronary artery is involving, they don't have the classical falciform or secular type of aneurysm. They are more uniform type of dilatation of coronary artery, and they do have aneurysm. They involve more distal part of coronary artery instead of proximal. So that is a difference in between KD and also MISC. Okay, so and in MISC, a lot of studies also show that when the children are younger, when younger children get MISC, their features are more KD-like, and those with the older children with MISC, they are more higher risk to get myocarditis and also shock. Okay, next, we have to differentiate in between COVID-19 and also MISC. So in MISC, most of the children are previously healthy. And MISC, they have known history or suspected COVID-19 infection about weeks before the onset of fever or inflammatory symptom. Okay. Acute COVID-19 infection, they have more severe lung involvement. Okay, but in MISC, very lesser, and majority of respiratory symptoms in MISC are usually related to cardiac dysfunction or shock. Myocardial dysfunction and shock is more common in MISC. GI symptom is more common in MISC as well. And mucocutaneous signs are more common in MIC, even though some acute COVID infection do reported to have some cutaneous sign. Okay, so certainly, again, inflammatory marker is much higher in MISC. So MISC basically an inflammatory hyperinflammation disease, and lymphocytopenia, again, lymphocytopenia, thrombocytopenia are more common in MIC. Okay, next. This is the diagnostic algorithm that is suggested by American College of Rheumatology. Okay, so any children who have unremitting persistent fever more than 38 degrees, there is a link to COVID-19 infection. With at least 2 of these symptoms, we need to investigate for possible MISC. So that's why I always advise the nurses also in the hospital, if your child have COVID before, contact with COVID, may or may not tested for positive, and now about 2 weeks to 6 weeks after the contact or COVID infection, you have persistent fever, you have some GI symptom. I would say GI symptom is very important. We have conjunctivitis, red lip, a lot of rashes. Please come forward. We need to make sure your child not getting MISC. So if the child is not in shock, we can go for tier 1 investigation. That will be full blood count, they call CBC. Those are complete metabolic profile is liver function test, renal profile, ESR, CRP, and PCR test. And see from here, if the CRP is high, ESR is high, you have a low lymphocyte, low platelet, low sodium neutropenia. So you have to go for tier 2 investigation, all the troponin and more specific inflammatory marker. But if the child went into shock, immediately go for tier 1 and tier 2 investigation. This is what's suggested by American College of Rheumatology. So I think this is very useful. because we believe there will be a peak of MIC cases next month. So any kids come to you with contact with COVID, or there's COVID infection a month or 2 weeks before, with fever, with GI symptom, rash, mucocutaneous sign, please ask them to go. Please first look at them and make sure they are not in shock. Okay. Then if they are not in shock, they're still stable, go for the tier 1 test, do all the full blood count, renal profile, liver function test, ESR, CRP. So if anything suggestive of MIC, go for tier 2 test. If they are in shock straight away, hospitalized, go for tier 1 and tier 2. Okay. So management of MIC is still evolving. So that's why some of them say, patient under investigation without life-threatening, you can go for investigation before immune modulator. But some experts think that even without life-threatening, you should admit.
Hello? We lost Dr. Ang for a while there. Ang? Ang? Are you there? Maybe he has problems with his Wi-Fi. Ang? Okay, so basically, for all the people who are not medical, okay, shock means very low blood pressure. So any shock syndrome, basically the blood pressure is very low, unable to maintain good organ function. So that is the meaning of shock. And for all the lay people out there, especially parents and teachers, so if you know of any child that has had the fever, okay, and you have that history of COVID before a week or a few days or 2 weeks, always make sure they come in and get themselves checked for a few tests that Dr. Ang has said. Now, I really do not know where Ang has gone to. Okay, I think he will be back soon. So let me see whether Ang is still here or not. Okay, I have 10. Ang is still here. Ang, what happened to you?
No, I think the internet issue, sorry.
Yeah, okay, good, you're back.
Yeah. You can see me?
Yeah, I can see you and I can see the slides. You just have to put on the slideshow.
Okay. Sorry, I think it's the internet connection.
Yeah.
So, okay, so like just how I said, so for the management, it's still evolving in the course.
Again, Dr. Ang's internet is really, really unstable. We need to find out what the internet he's using, and we shall not sign up for the internet. So is there any questions? Please just feel free to send in your questions. We will take the question Q&A at the end of it. Let me just see whether Ang is still here. The problem with it is because I'm worried he can't come in if he's out, because we are full, you see. Ang? So again, if you don't know the terms, you can ask us also.
Yes, we can hear you.
Hello? Hi, Dr. Betty, can you hear me? Hello? I think Dr. Betty off the...
Okay,
yeah.
You're back. I never happened before, okay?
So you're disconnected, I think.
I was disconnected completely. I panicked.
I also don't know why. I talk, suddenly the whole thing just disappeared.
Yes.
But the internet still go on.
No, you disappeared initially. I could still speak. And then suddenly my Zoom...
also disappeared.
Okay, come, we continue before anything else happens.
Okay, sorry, I think
It's
too
okay.
many.
Maybe no, we have had 100 before. Okay, go on.
Yeah. So what is suggested by ACR, American College of Pneumatologists, is like whoever has this feature, we should admit them. Whoever have abnormal vital sign, tachycardia, tachypneic, admit them. Any form of respiratory distress, admit them. If they have neurological deficit or change of mental state, of course, when they are very lethargy and so on, we should admit them. If they have any abnormal renal profile, high creatinine for age, any high liver enzyme, admit them, even though it's mild. Of course, marked elevated inflammatory marker, which admit them, abnormal ECG, BNP, and so on, which certainly have to admit them. Okay, so even for the expert, especially for American College of Pneumatology, they also come out with version 1, version 2, and version 3. So now come to version 3 in February this year. So whoever hospitalized, start IVIG, 2 grams per kilo, okay? And start them on low dose methotrexate, 1 to 2 kg per day. But because methotrexate is quite expensive, so in some of the KKM hospital, they actually give them IV dexamethasone, which is cheaper compared to methotrexate. And it found that it's also worked very well. So for those with a refractory diseases, then they will give intensification treatment. That means they will give higher dose methotrexate, or in KKM, they actually give high dose dexa, or you can try infliximab, anakinra, interleukin-1 antagonist, and so on. So that is, and most of the time from my discussion with my friend, most of the time, they work very well. But I see even the treatment also is still evolving. Okay. So most are expecting those with just mild symptom, just monitor them, don't start immunomodulator treatment, that means IVIG and so on, okay? There's still uncertainty of empirical use of IVIG in the setting of preventing coronary artery aneurysm. But in this MIC, coronary artery aneurysm is not that common compared to Kawasaki disease. And they use a stepwise progression of therapy. So IVIG followed by low dose prednisolone first. If they didn't respond well, they will give high dose methotrexate, anakinra, or infliximab. Okay, but majority of them will work very well. I never heard of anyone requires second IVIG. But of course, for those like, because 50% or more than slightly more than 50% of them will have LV dysfunction. So before we give the IVIG, we do need to assess the cardiac function and also the fluid status, whether the patient is fluid overload or not. So some of them actually give divide the 2 grams per kilo of IVIG into 2 days. They give 1 gram per kilo daily for 2 days. And second dose of IVIG in general is not recommended because there's always a risk of volume overload and also hemolytic anemia. And after we give the IVIG and methotrexate, we always have to guide with our lab test and cardiac assessment to guide us whether we're going to taper down the methotrexate or not. So usually it takes about 2 to 3 weeks to taper the medication. Okay. So next is how we monitor them. So for those with cardiac dysfunction, abnormal BNP, TROP-T, we had to continue monitor over time until it normalized. And those, even though you have a normal ECG, we still do the ACG every 48 hours when the patient requires hospitalization, because every block happens in 20% of MISC. Okay, and echo had to be done at diagnosis and then follow up them. If you have cardiac dysfunction, valve regurgitation, pericardial effusion, coronary artery dilatation, of course you're going to to monitor them more closely. If not, you have to repeat the echo at least 1 to 2 weeks later and 4 to 6 weeks later. So the minimum we require 3 echo. Is quite similar to Kawasaki disease. Of course, in advance, in more developed country, they actually want them to have cardiac MRI. I think a lot of our center, for example, Sarawak and so on, they also did cardiac MRI for those with MRIC to check whether they have any, to check their LV function, any scarring, any fibrosis and so on that on the myocardium. And of course, like a lot of coronary artery aneurysm involve the distal coronary artery. So sometimes we do not able to see it by echo. So sometimes we do need cardiac CT angio to actually find out or actually evaluate the coronary artery aneurysm. So I think a lot of people say, why you start MISC with low dose aspirin? I think because what postulated for MISC beside the hyperinflammatory is a hyperinflammatory disease. They believe this is also an immune-mediated vasculitic lesion or vasculopathy. So we have to monitor them. That means we need an echo 4 to 6 weeks later to confirm the coronary artery is not involved. So no choice. Once you diagnose MISC, similar to Kawasaki disease, minimum you have to start them on low dose aspirin for at least 4 to 6 weeks until your next echo at 4 to 6 weeks to confirm that it's normal coronary artery, then you stop it. The only contraindication is the child have an active bleeding because they tend to have a low platelet, so platelet count less than 880,000, you don't start, okay, or any significant bleed. And MISC is a thrombogenic type of disease, so they are higher risk for thrombosis. So those with a central line, age more than 12 years old, malignancy, ICU admission, high D-dimer, greater than 5 times from the upper limit, they are higher risk. So please start them on at least low dose aspirin. And if there is a coronary artery involvement, the anticoagulation therapy will be similar to KD. So those like G-score of the coronary artery still in between 2.5 to 10, start with low dose aspirin. If more than 10, then you need the low dose aspirin plus therapeutic anticoagulants. Okay, either Clexane or warfarin or DOAC. Okay. So for those with very poor cardiac function, similar to adult patient or all this cardiomyopathy, when the ejection fraction less than 35%, they should also receive low dose aspirin and also therapeutic anticoagulant until the ejection fraction more than 35%. So the therapeutic and anticoagulants is listing. Okay, warfarin, DOAC, or enoxaparin. Okay, so for MIC patient who has documented thrombosis, you also have to start low dose aspirin plus therapeutic anticoagulant for 3 months, and then repeat the scan or imaging to find out whether to continue or not. Okay, in conclusion, I will say before the internet get cut off again.
Yes.
MISC is a rare. The incidence is not sure, but probably less than 1%, but it's a serious complication of COVID infection. So we have to watch out, and we have to aware about this complication, because we believe next month will be the peak incidence of MISC in Malaysia. And timely diagnosis is important because our DG give a figure of 100%, but majority of the Western country and European country or US and so on, their percentage of LV dysfunction is slightly more than 50%. So I still say it's a majority of patients still presented with shock or LV dysfunction. So you must make sure we diagnose it timely, but I'm not quite sure whether we should admit all the patient or not. Okay, some experts said no need, some depend on the test and so on. Some experts, even the patient not in shock, they still admit the patient. Okay, So if the patient presented with shock, we resuscitate them accordingly. Okay, immunomodulator therapy should be used to treat MISC. This one, there's no doubt. And in refractory disease, we use intensification therapy. And patients with MISC are at risk of thrombosis. So thromboprophylaxis is a must in this group of patients. Okay, good thing is most of the patients, even with cardiac involvement, recover well and recover their function, recover to normal function on hospital discharge. And from what we know is majority of patients will respond quite well. By 3 to 4 days, they'll be okay. After the IVIG and also METAP, they're back to their normal function. So with those who have cardiac dysfunction, we have to follow up them for after discharge, but we're not sure how long to follow up them. And certainly lastly, we don't know what is the long-term effect of this MISC. Thank you. Okay, very interesting indeed. So please send in your questions. Okay, we have some questions. Basically, Kamala Kanan asked, is MISC, is it common after the post-COVID infection due to neutralizing antibody, or is it after mRNA vaccine? I think, where's Dr. Ang again? Yeah. Okay. Yeah. So I never heard about MISC post-mRNA vaccine. That's why, like some experts say, we shouldn't give the vaccine after before 6 to 8 weeks after you get the COVID infection, because you may confuse. People will think that mRNA vaccine causing MISC. But I think up to today, no one actually documented that mRNA vaccine causing MISC. So we try not to give the vaccine before 6 to 8 weeks post-COVID infection. Otherwise, the anti-vax will say the vaccine causing the MISC. So okay, I will say no, yeah. MISC is due to COVID infection. So it is important to stress here that MISC is due to COVID infection in the child and not due to the vaccination, yeah? So Ji Ling Ki asked, how do you treat mild myocarditis? But in fact, how do you treat, okay, you're treating the MISC with the immunomodulator, but how do you treat the myocarditis in the child or severe heart failure in the child? It's still the same treatment. The same treatment. Because you see, a lot of our treatment actually brings down the blood pressure. For example, you know, after the reduction. Beta, do you use all that? Beta blocker. You have a because child in shock. MISC is due to it's an immune mediated vasculitic lesion or vasculitic or hyperinflammatory. So a lot of time they respond very well to immune modulator treatment. Myocarditis, from my experience, a lot of them, some of them respond quite well, some didn't respond. So we back to our usual cardiac failure treatment. That means we have to support the heart, rest the patient, rest the heart, reduce the afterload, and so on. So the treatment will be a little bit different. I think the only difference is MISC most of the time respond very well to immune modulator treatment. Myocarditis, some of them respond well also, some of them take a bit longer time. I do have experience that we need to ECMO myocarditis more than a week, but at the end they still recover. Okay, Dr. Cole, but may not recover to full function. Okay. Dr. Cole raised the hand. Do you want to ask a question? But we have a lot of questions coming in, and we have Dr. Ang. Dr. Ang, I got 2 questions. In MISC, the fever
is due to what? Because there is no viremia, there is fever. And what's the cause of the fever? Number two,
Inflammation,
Inflammation.
hyperinflammation.
of the inflammation itself. Okay, thank you.
Yeah.
And second question is, when you use a IVIG, this IgG, is it specific to COVID or is just a pool IgG?
It's still a pool IgG that we use for KD.
Why
It's a
can't we
pool
use
IgG.
why can't we use a IgG that's specific to COVID? Since we can get
Do we
the
have
thing
IgG
from,
that's specific to COVID?
I mean, we can get it from the
And I don't think.
plasma of recovered patient.
Huh?
Okay, I think the pathophysiology is different lah. So if you say you want to use an immunoglobulin that's specific to COVID, then you treat acute severe COVID infection, yes. But we use a pool IgG is to use as anti-inflammatory treatment instead of specific to COVID virus, because the pathophysiology is hyperinflammation.
Okay. So Jin Key asked, how do you treat mild myocarditis? I think we have answered that question, as in this case, we use IgG to treat the whole systemic disease. And therefore, with that, it would treat the myocarditis and the poor LV function. Am I right to say that?
Yeah.
Okay.
I think the adult treatment also the same.
Okay. So do you get this kind of multi-system disease in adult?
There is MISA, but I never seen the MISA because I'm pediatrician.
Okay. Do you
We
mind?
don't see anyone more than 18.
Okay. Do you mind unsharing your slide so that I can share the QR code?
Okay.
Okay. So somebody asked, if a child comes with fever after a month of COVID infection and COVID RTK is positive again, should we treat reinfection of COVID or MISC? Oh, okay.
Okay, so when you get a COVID infection, then again the RTK is positive again.
Mm-hmm.
Yes, of course you can have reinfection of COVID-19, but same thing, if the patient fulfill the criteria of MISC, I will treat the patient as MISC.
Okay, basically the shock, multi-organ failure, I think the whole list of criteria has been shared just now. Discussed just now.
Because I believe and we know that COVID infection in children are usually mild, but MISC can be life-threatening. So as long as patients fulfill the criteria, that means with the clinical presentation and laboratory test suggestive of MISC, I will treat the patient as MISC instead of COVID. COVID, we have nothing to treat in children. Majority of them are okay.
Okay, we have, will COVID vaccination reduce risk of MISC? I think that is definitely.
Certainly, yes.
Yes.
You don't get COVID-19, you don't get MISC.
Yes. So there is a question from Facebook. If after vaccination, isn't the child still, the child still have a chance to get MISC? I think so, because not everybody is protected.
Immunized, yeah. Seroconverted to COVID. Even you get COVID infection, you still can get COVID infection again.
That's right. Is it possible for MISC even though after 3 months of initial COVID infection? We don't know, right?
We don't know. You may get a second COVID infection, which is asymptomatic. So as long as you fulfill the criteria, I will say I will treat as MISC at this pandemic.
Okay, somebody asked about they are a bit worried about vaccination. What is your opinion on the need to vaccinate children?
I certainly support the vaccination. I will say vaccination is relatively safer than getting a COVID infection.
Okay.
And one of the very important thing that we always think is like, what is a long-term side effect of COVID infection? I think a lot of parents and so on are worried about long-term side effect of vaccination. But what about long-term effect of COVID infection?
Yes.
You see, COVID infection itself, I know this question is like, COVID infection in children usually mild, but you can see the complication is bad. We haven't known what is a long-term effect on COVID. You see, in adult, we have a long COVID syndrome. You have loss of your cognitive function, you become slower, you're less active, got chest pain, you got breathless, you're coughing. So we don't know what's going to happen. If it can happen to adults, certainly it happen to kids. So certainly we want to prevent our kids from getting COVID infection.
Okay, we go on to, okay, so vaccination we have done. After treatment with IV methylpred or for MISC, the cardiac damage, will it be permanent or is it reversible?
Somehow, from what we get from the most of study or the review, most of them actually recover very well. Very few of them have scarring or fibrosis on the myocardium by MRI, cardiac MRI scan. So I would say the prognosis is very well. So I would say if we can timely recognize this MISC and treat early, the prognosis is excellent.
Okay, there is a question about a COVID positive mother who has just delivered. Is the infant safe with the mom? Would you put them together in a room?
Well, this one very out of topic.
Yeah, very out of topic. But then because we have quite people who are
okay, again, COVID infection mom. So depend on which day of the COVID infection. Okay, in Sunway also we have a lot of COVID mom actually delivered their kids. So same thing, if the mom have COVID for more than 7 days or whatever, certainly mom will pass the antibody to the kids. The kids should be safe.
yeah.
If the mom just getting COVID today and the baby delivered today, probably I will isolate and make sure the mom is recovered before I put the kids together. But at the same time, we have, because during the MCO, we do have patient like, I do have experience that mom have COVID infection. At the 1 or 2 day or the same day they deliver the kids, we have to isolate the child following the SOP. And then we also swab the baby and monitor whether the child get congenital COVID infection or not. So it depends on the day, how many days the mom has get the COVID infection.
Okay.
If just the first few days, I will isolate them.
Okay. How long should we wait before letting the child to continue with the national vaccine program after MISC? Do we know?
Oh, after the MISC, how long after the patient had recovered from MISC? Okay, so good question. I never thought of it, but I think it should be, if you have cardiac involvement, it will be similar like myocarditis, pericarditis. For example, when we start the vaccination for kids, they do ask the child, we have history of myocarditis. Do we still vaccinate them? Yes, 6 months after myocarditis. So I believe this principle still apply to the kids. If you have MISC and you have myocarditis kind of thing, wait for 6 months.
I think there's extrapolation, but then I think it is sensible in that sense, right?
Yeah.
Yeah, it's sensible. Okay. Current understanding from KKM was to allow COVID vaccination as long as patient recover from COVID infection and out of isolation. Should we practice?
Yes.
Should we practice to advise patient to defer vaccination for 6 weeks?
So of course, like by right, once you completed your SOP as early as 2 weeks after your COVID infection, you can go on for your COVID vaccination. But same thing. So, but this 2 weeks to 6 weeks is a period is a time frame to get the MRIC. So if you get the MRIC at the same time, then people will blame the COVID vaccine. So there's no right or wrong answer for it.
Okay, a lot of people are just worried about the COVID vaccine more than the COVID in itself. Faha asked, considering the risk of severe COVID complication, which is MISC, is very low in children, how does it compare with the risk of vaccination, specifically after vaccination for 5 to 11 now that is implemented in Malaysia? In your practice, do you see children coming with severe or rare COVID vaccination side effects?
So far, I don't see any severe side effect. So from what we can see, what we know, they see what our KKM reported, I saw the report today, they do reported about 6 or 7 cases of severe side effect. But you compare MISC and the pediatric death due to the COVID infection, side effect due to vaccination certainly much lower compared to the MISC and also severe COVID. So in terms of benefit, I think we should go for vaccination. So vaccination still much more safer than getting COVID.
Okay, I want to say this. Basically, I have not seen any vaccination complication until recently. I saw a lady with actually coming in with thyrotoxicosis due to COVID vaccine. And why do we say it's COVID vaccine? Is because she had the second dose of Sinovac and then she had palpitation for 2 weeks and then it settled. But when she had the third dose, it went on for 3 weeks. And then she was actually seen in emergency twice, and they told her it was panic attack because the ECG was just sinus tachy. But it turned out that she had very abnormal thyroid function with a very low TSH. So she's been treated and she's currently well. And then her son had COVID vaccine and he had Pfizer. And he also had palpitation following the vaccination. And he, instead of, we thought it was also thyroiditis, but instead he was actually arthritis. After the palpitation, he developed joint pains and actually he had arthritis. So it settled with a low dose of steroid. So I think there are people who already have underlying immune problems, so making it them more prone to immune problems following the vaccination. Can mother breastfeed if the mother is COVID positive? Can mother breastfeed? Where is Ang? Ang?
Yeah. So mother, that's why the question is not clear. Can mother breastfeed if mother is COVID positive?
Yeah.
So most likely the kids already...
For newly born, she wrote there for newly born.
Newly born.
Yeah.
So that's why, like just how I said, is when is a mother actually COVID positive? That means, okay, after delivered, mother got COVID positive. So whether the child also will get infected or not. So actually, who passed the COVID to the mom?
Yes.
So this question, I think you need more information because like just how I said, mom already positive for 7 days. mom already positive for 7 days or more. So as long as mom wearing a mask, we still can continue breastfeeding. But it's like mom positive after they delivered the baby may also actually get infected. So it's depend on the whole thing. So this scenario had to have more history. This one very hard to answer.
Yeah.
So yeah, too general to answer this question. Can the mother breastfeed a newborn if mom is positive? I think it's too general. We have to be more specific to it.
There was a child, 13 years old, who died after vaccination, after 2 weeks. And again, that is a very too general a statement. I think
Yeah.
unless you are medical, I hope you are.
I think that is a case like under postmortem or under investigation by KKM. I think we don't comment on that one. But in general, I will say, you see, we report all the same thing. We report all the adverse drug effect. We report everything. Even you take a Panadol, you go out from there, you cross the road and you have a MVA or road traffic accident, you also blame the Panadol, right? You also blame the
Panadol, they
paracetamol.
won't blame, but if it's statin, they will blame.
Yeah. So they can blame everything because everything can be called incident. So I will say this one is very hard to answer. We let KKM to investigate, and this one is too.
Yeah. Okay. I think we have yeah, we already. Any more questions? If not, we will end here. Okay. We still have a lot to learn because we do not know. Even COVID infection in itself is how you call it, is evolving. Yeah,
It's evolving.
evolving
It's a
because
new
mutation, because of COVID vaccine. We don't know enough sometimes. Okay, but a lot of people seem to know too much and seem to claim many things. But I think that it is safe to say it is better to be vaccinated than not to be vaccinated. Okay. Okay.
Last question.
Okay, last question. Okay, I share the QR code again. Let me share the QR code again. Okay, go on.
Dr. Ang, earlier
Yeah.
you mentioned about fibrosis after myocarditis. I want to know actually how long after the myocarditis or recovery from myocarditis fibrosis can be seen on MRI. How long after the incident?
Okay, usually they will do the MRI about 4 to 6 weeks later. So actually, they give a contrast. So whether they have a leg gate enhancement or not. Yeah, but majority will not have the fibrosis lah.
So the earliest we can see should be about 4 weeks if there is fibrosis. 4 weeks after the recovery.
Yeah, so that's why a lot of time they will suggest that we do the MRI about 2 months later.
Okay. Thank you.
But most of the time will be okay lah. That's why most of the patient actually recover. So MRIC is rare. Myocarditis also probably that means there will be myocarditis on the heart. So once we treated, hopefully the fibrosis and scarring will be rare. So that's why we say that this is a pretty new disease and we're still learning from it, like Dr. Betty said. So a lot of things we still don't know. So the long-term complication we also still learning. And even a long-term complication of COVID infection, we're still learning. We don't know. For example, I also can postulate that when a kids get a COVID-19 infection, they probably perform poorly in their school. We don't know. Maybe 5 years, 10 years later, they have performed poorly, right? We don't know. They may have effect on the brain. We don't know. because in terms of adult, we have long COVID syndrome.
Okay, I think
So I would say better vaccinate.
Yeah, better vaccinate. The take-home message is we think that it is much safer to vaccinate and prevent the infection. And maybe that is the only way to actually halt the transmission of infection in schools and school-going kids. And the take-home message here is that you know about the existence of MSISC after the COVID infection and not after COVID vaccination. Okay, so all are aware that there is such a disease and how to diagnose it and how to come to hospital early because there is a treatment. And is there any other take-home message here? I think we're done very well. I find the talk very, very interesting and very, can I ask
Interesting
you?
Discussion.
How?
Interesting discussion.
Yeah, how is the shock? What is the criteria for shock? What is there a cutoff point for blood pressure or is it perfusion? What do you think that is? How do you diagnose a shock in a child?
Okay, shock in a child is different than an adult. Is right. Like we do have a normal BP for age. If you lower than certain BP, then you consider is low BP.
Okay, but of course, in a child, one thing I have done quite a little bit of pediatric, though I really hated it, is that when a child doesn't look well, the doctor must be able to identify a child that doesn't look well. That is extremely important. It doesn't matter whether you're a GP, you're a medical officer, it is extremely important to identify a child that doesn't look well. And I think then you would know that you should refer for admission. Okay, actually I got some questions, but I think everybody asked it for me. Yes, and okay, I will bump into you one day in the hospital, maybe, since I've never bumped into you before. And join us next week for another webinar on Wednesday, 9 p.m. I think it's acute coronary syndrome by, I've forgotten. I think it's acute coronary syndrome by David Quack. So we're going through a series of cardiology for the next 4 weeks or so. And we have acute coronary syndrome, we have sudden cardiac death, following which, so you will know all of it will be announced in our page or in our Telegram group chat. Thank you very much.
Thank you.
Thank you. Bye.
Bye.